Good afternoon. Welcome to our long COVID and post-viral syndrome echo with the University of Utah Health and Bateman Horn Center. I'm Talia Ruscioni. I'm the education director at the Bateman Horn Center, and I run these sessions with echo manager Sarah Day. Today, we will be hearing from Dr. Braden Yellman and FNP PT Teresa Dow as they discuss anatomical neurological complications in long COVID and ME/CFS. Dr. Klinger she had planned on joining us today, but she is now unable to, so Dr. Yellman will be filling in for her. I'm going to turn the time over to Dr. Yellman to kick us off.
All right. Hello, everybody. I'm Braden Yellman. Today we'll be discussing anatomical neurological complications in long COVID and ME/CFS. We don't have time to cover the whole gambit of it. There's a lot to kind of get in the weeds with when it comes to craniocervical instability. So we're going to kind of stay a little more focused today. And as you can tell, I am not Petra Klinge, but I do have a few of her citations here in this short lecture. I have no disclosures. Bateman Horn Center is a nonprofit center of excellence that works in ME/CFS, PASC, and related comorbidities. So what are some of the neurological and spinal manifestations we see in ME/CFS and long COVID? Well, they actually overlap very strongly with those that we see in hypermobile Ehlers-Danlos syndrome and other Ehlers-Danlos syndromes and connective tissue disorders in general. So you can see, in particular for today's purposes, I wanted to bring attention to acquired or occult tethered cord syndromes, and I believe we have a case regarding that. Often related to that are found in the same individuals are issues with craniocervical instability or atlantoaxial instability. But the gambit can run to Chiari malformations, idiopathic intracranial hypertension, headaches, migraines, spinal kyphosis, dystonias, Tarlov cysts, and a lot of abnormal neuromuscular features as well. So in our patients with connective tissue disorders, there are often incompetent connective tissues that may result in the laxity of ligaments, especially in the axial skeleton, in the peripheral nerve sheaths, and even in the architecture of the myoneural and muscular end plates. So neurological manifestations may arise from associated weakness of these ligaments, and it's particularly in the craniocervical junction and in the spine. You can also get early disc degeneration, weakness of the epineurium and perineurium surrounding peripheral nerves as well. Ligamentous laxity in particular can lead to nerve structure entrapment, deformation, and biophysical deformative stressors. And these stresses are thought to then potentially contribute to secondary altered gene expression, altered cellular function, altered neuronal function, and altered phenotypic expression down the line. So this is titled craniocervical instability or atlantoaxial instability, but it really relates to a lot of peripheral nerve structures. There is this increasing recognition of the formation of axon retraction balls or bulbs as a result of stretching or deformative stress injury upon neurons, especially in our hypermobile population. And these are findings that are actually similar to what we see in diffuse axonal injury of the brain. And this stretching of neurons then causes this pathological influx of calcium, which leads to altered gene expression, and you can even get apoptosis. So we see this in peripheral nerve structures. We see it at the craniocervical junction as well, and it may also be happening in the spinal cord. Here I wanted to just briefly remind everyone that our HEDS patients or our patients with connective tissue disorders have significant overlap with those that have POTS or other dysautonomia symptoms, and significant overlap with patients that have mast cell activation syndrome. And if you've been coming to these echoes, you're starting to realize these are all comorbidities that are found in our long COVID and ME/CFS patients. While not universal, extremely common. So it bears mentioning that nearly 1 in 3 patients with mast cell activation had a diagnosis of hypermobile EDS in a large sample of patients diagnosed with either disorder. There's also studies suggesting that 66% of patients with POTS and EDS meet criteria for mast cell activation. And so why am I focusing on mast cell in particular here? Well, we'll come into that. So brief reminder, mast cells can get activated and release a collection of inflammatory mediators, cytokines, and proteases. Histamine is the most famous of those. We also get tryptase and leukotrienes, but there are all kinds of inflammatory mediators that come from mast cells, and simplifying them down to histamine alone, I think, is doing us a disservice. Mast cells are normally activated in the presence of antibodies known as IgE antibodies, as well as several types of immune triggers. But that can become aberrant in mast cell activation. Activated mast cells also send distress signals throughout the nervous system and the immune system to other areas of the body, and they can alert additional mast cells to activate as well. So this is to say that you may have a mast cell reaction, for example, in the gut after taking a medication, after eating something that you might be, say, allergic to, or maybe even after a chemical smell. I know more than one patient has told me going into the auto store and smelling tires can be really activating. But that can have not just local inflammatory effects where you're encountering that smell, where you're encountering that tablet in your GI tract, but it creates this downstream signal transduction to mast cells in all different parts of the body. So that initial GI trigger can cause a mast cell activation in neurological structures. So mast cells produce inflammatory changes in our connective tissues, and this can affect all kinds of organ systems, as I was alluding to. For example, we can see localized peripheral nerve, epineurium, perineurium, and endoneurium activation with releasing mediators that may activate nociceptive symptoms like a peripheral neuropathy, can trigger headaches, can even trigger or worsen symptoms of small fiber polyneuropathy. We see that mast cell cytokines can lead to dysfunctional fibroblast proliferation in nasal and bronchial tissue with associated rhinitis and sinusitis. We do think that fibroblast proliferation may also be happening in other structures and may be related to tethered cord. Mast cell induced TGF beta upregulation occurs in bronchial smooth muscle cells and can modify matrix proteins of the bronchial parenchyma and contribute to tissue damage and asthma-like symptoms. TGF beta upregulation in esophageal tissue causes proliferation and smooth muscle contraction, which may lead to symptoms of dysphonia, dysphagia, globus, or even eosinophilic esophagitis, some things that I've seen in this group of patients at very high levels. Mast cells in local connective tissues can cause microenvironmental changes to the extracellular matrix, including IgE-mediated autoreactivity, which may play a role even in rheumatological conditions. And then we see laxity of blood vessels with pooling of blood in the extremities, like we see in POTS patients, those with dysautonomia, ME/CFS, and PASCA as well. So these cytokine mediators have all kinds of peripheral tissue effects, and they can all be activated by a single source of interaction, again, say in the gut or in the nasal cavity. I think it's also worth just pointing out, for interest's sake, that mast cells may serve as hosts for the SARS-CoV-2 virus by expressing the ACE2, which we have known is an important receptor for this virus upon host cells. And so upon stimulation by SARS-CoV-2, mast cells may rapidly secrete preformed granules as well as inflammatory cytokines and chemokines within a 6 to 24-hour period. And we know even that utilizing mast cell stabilizers during acute infection does seem to reduce the risk for long-term development of PASC or long COVID. So jumping into acquired or occult tethered cord syndrome, and I will tie these together. What is this? Well, this is an anatomical restriction of the normal movement of the spinal cord via the filum terminale, with a tightening or tethering abnormality as that filum attaches to the surrounding soft tissue or bony structures and the conus medullaris. So a healthy filum is consisting of fibrous, collagenous, and elastic bands that connect the conus medullaris to the dural sac, usually at about the S2 level. But the filum appears to be morphologically altered with fatty tissue, dysplastic axons, what we call nerve twigs, fat and vascular lacunes, and even congested veins when we have tethered cord syndrome. And the pathology is thought to be from forcible flexion or stretching of the spinal cord against the filum, causing this tissue damage and repair and this local continued inflammatory pattern. We also have strong reason to believe that there is a secondary or maybe even primary mast cell activation occurring in these areas from this forcible stretching and these mechanical forces, and then also a related altered gene expression like we talked about earlier within neurological tissues in our patients with connective tissue disorder. And though we don't have the exact data here, it is my understanding that Dr. Klinge has been evaluating tissue in tethered cord surgeries that she's removed, and is finding increasing evidence for mast cell damage and mast cell presence in these areas. So when someone has this pathological change of tethered cord, what might be their symptoms? Well, there's a classic triad, which includes a neurogenic bladder, lower extremity weakness and sensory loss, and lower back pain. But this can really be expanded to things like unsteady gait, loss of lower extremity sensation, pain, which can be migratory in the lower extremities or very positionally based, urinary frequency or urgency, a sense of frequent urinary tract infections or actual urinary tract infections because people are not completely emptying their bladder, associated dysuria and urinary retention. We may see gastrointestinal problems or dysfunction, significant lower back pain, a pulling sensation in the lower back, or actually in the occipital area. Can present in either area, suboccipital pain or pressure. And one thing that I always ask my patients is, can you walk on your heels, or do you find that you're toe walking more often? That can be a really sensitive sign for detecting occult tether cord otherwise. So how do we diagnose tethered cord? This is sort of a work in progress. We are trying to get better at it all the time. Urodynamic testing with a urologist to evaluate for neurogenic bladder manifestations can certainly be helpful if there is neurogenic bladder without other cause, and we have a patient with long COVID or ME/CFS or EDS or POTS or mast cell activation or all of the above or some combination. That certainly gets our spidey senses tingling. Somatosensory and motor evoked potentials are something that's been requested by a lot of our neurosurgeons. These are not really quite mainstream yet here in the United States, but I'm hoping that changes over the next few months to years. But in Europe, these are being used to evaluate for tethered cord more frequently than here in the United States. What I often end up having to revert to is a lumbar spine MRI that is done at a 3 Tesla level of magnification. And this is both in the prone and supine positions. And there's a specific protocol that's being used for this. You can't just replicate this at any old imaging center if you want it to actually turn out with the degree of resolution that we need. But when you put a patient in a prone position and then switch them to a supine position, in a normal person that's non-tethered, you'll see particular movement of the conus. If there's less than 25% motion of the conus, when you switch positions, that is highly suggestive of an underlying tethered cord. So normal supine MRI, people have those all the time. This is not adequate for evaluation of tethered cord. So just because a patient has a normal lumbar spine MRI and a few slip discs, which of course you're going to see in our EDS patients, that does not rule out tethered cord. So what do we do for treatment of tethered cord? Generally, a surgical detethering is a viable option for patients who are presenting with moderate to severe symptoms, as well as radiographic findings. It is interesting, though, that even after detethering, there are some cases that may retether again over time. And again, we think that there could be continued abnormal forces. Maybe this is because the patient also has craniocervical instability and stretch and irritation in the cervical region on the spinal cord. There may be continued local mast cell activation syndrome or other downstream inflammation in the area. And sometimes that can even be triggered by the initial surgical intervention. And it may be worth mentioning that they actually use essentially Gore-Tex, the stuff you see in our camping materials, in a sort of surgical form to actually help prevent retethering. So the filum terminale could be part of the sensory motor system that is involved in spinal alignment, sensing non-physiological stretch forces from excessive spinal movements. And as such, when the filum terminale this filum terminale can actually be acting as a stabilizing force or a stabilizing syndrome in cases of craniocervical instability or atlantoaxial instability. And so you've got all these tethered cord symptoms. You've also perhaps got CCI symptoms that are occult that we're not recognizing. Maybe they're present. You go in, you do a tethered cord release, and now all of a sudden you don't have this stabilizing force, and you may actually have more motion in the cervical region and actually see more symptoms of the cervical medullary syndrome associated with craniocervical instability after release of tethered cord. So this surgical detethering may actually sort of expose an existing CCI or atlantoaxial instability. And it's sort of interesting. Sometimes that untethering may allow us to use things like cervical traction, physical therapy, other conservative measures to better manage symptoms of the cervical medullary syndrome or CCI. Other times that snipping of the final terminale and lack of stabilization may lead to more motion and more neurological irritation in those areas, which then may actually precipitate a greater need for neurosurgical intervention for CCI or AAI if also present. So we really have to think carefully about what we're doing when we pursue a tethered cord release. And with that, I will end the chat and let us get to some cases.
One thing to remember when even considering the diagnosis of tethered cord is that symptoms are often subtle or absent. So today, I hope with this case that you'll be able to recognize some of those subtleties and be able to be more effective at least considering tethered cord syndrome as a possible diagnosis. So this is the first tethered cord patient I came in contact with. So it's been about 5 years since I first saw this patient. And I specifically selected this case study because I felt it would give us an opportunity to look back and see were there hints, because at this point in time, I really was not familiar with tethered cord and it wasn't really on my radar. So we can kind of walk through that and see what may have signaled that this could possibly even be an individual with tethered cord syndrome. So this was a 32-year-old female. She had complaints of that are typical for post-viral illness, fatigue, headaches, migraines, muscle and joint pain, insomnia, dizziness, vertigo, gastrointestinal dysfunction, diffuse pruritus, cognitive impairment, and chest pain. So as you know, that's pretty typical for our population. So the onset of her illness was in November of 2016. It occurred with a sore throat, headache, photophobia, sound sensitivity, low-grade fever, rash, and fatigue. And then 1 week later, she developed several more symptoms. So she reports to the emergency department where they do a throat culture, and she's positive for strep G infection. She's treated for 7 days with penicillin. However, it does not improve her symptoms. So the next month, she becomes borderline anemic. She develops this sort of cervical radiculopathy, which radiates to her right shoulder. And then, which is very interesting, she expresses that slow walking triggers low extremity myalgia, which is kind of unusual for our ME/CFS patients. So January 17th, she continues to experience symptoms. Now she has insomnia, nausea, loss of appetite, temperature intolerance. And she is experiencing now severe pain increased with activity, especially walking upstairs. At this point, I'm just taking the history, but I do think that's kind of unusual. And I'm wondering, what is this severe pain all about? One of her providers at this point says, you might have ME/CFS, and she starts to look a little bit further into that. So February 2017, now she gets an MRI of her brain and cervical spine, which is unremarkable. Neurology begins to do their evaluation. They rule out multiple sclerosis. She goes to endocrinology. That testing is unremarkable, and she's referred back to infectious disease where they do a lumbar puncture, but it has unremarkable results. So in April 2017, a few months later, she's doing some more labs and she becomes IgM positive for the Epstein-Barr virus. Her symptoms continue worsening somewhat, and in December 2018, now she's walking 3 minutes per day, but that's triggering pain. She's using a mobility scooter, and she is working 15 hours per week, but it's from bed. So she presents to my office in February of 2019. So she's been ill about 2 years now. And these are her complaints. You know, she has chronic fatigue. She reports post-exertion malaise. She has headaches, insomnia, difficulty falling asleep, restless sleep, frequent wakening, difficulty falling back to sleep, and of course, her sleep is unrefreshed. She has neurological and gastrointestinal symptoms, allergies, pruritus on her back. She's flushing. She reports canker sores, neurocognitive dysfunction, cardiovascular. All she really complains of is chest pain. And then in regards to pain, she reports migraining intermittent muscle and joint pain. And the muscle pain is mostly in her legs and arms. Her joint pain is all over, primarily in knees, elbows, wrists, and fingers. She continues to have that pain from her cervical spine, and she describes the pain as burning, hot, aching, and dull. So what I find interesting in my differential, when they complain of joint pain, I usually look more closely at mast cell activation syndrome, because I seem to find that that pain is many times triggered in the joints. So at this point, with the pruritus and the joint pain, I'm looking at mast cell activation too. So when I looked back at this case and looked at my physical exam, I was very disappointed in myself, but you live and learn. So I looked at her exam and it seemed relatively unremarkable. She did not meet the criteria for hypermobile spectrum or hypermobile EDS. I thought she had an unremarkable neurological examination, and I'm sure if I did it today, I would have different results. Her deep tendon reflexes looked about the same. She had a negative Romberg. So nothing particularly unusual about that physical examination. However, she did meet the criteria, or in her NASA lean test, it looked suspicious for postural orthostatic tachycardia syndrome. She was only able to stand for 5 minutes, and basically it was pain that had her sitting down. I also did some labs. We looked at Lyme's disease. The mast cell mediators were unremarkable, and as we've learned, those are difficult labs to have positive outcomes with. Immunoglobulins, lymphocyte subset panel, maybe slightly low white blood cells. I did run several endocrinological and rheumatological labs again, and they were unremarkable. And then again, with infectious disease for Epstein-Barr virus, IgM, and early antigen was positive. So initially, here was my treatment plan. I looked at the postural orthostatic tachycardia syndrome. I decided to treat with pyridostigmine bromide. I treated Epstein-Barr virus with valelcyclovir. Typically, I will keep them on from 4 to 6 months to see if they have any response. We did look at her other symptoms and tried to do something for her sleep and fatigue, and began some basic medications for mast cell activation. And then we tried to rule out the cerebral spinal fluid leak, because that's where I was going at first. Considering the lumbar puncture and the worsening of symptoms, I thought perhaps it could be that. However, that was ruled out. What we did was an MRI of the cervical, thoracic, and lumbar spine, sent it to a specialist for CFS leaks, and he did not think that she was a candidate for further evaluation. So her symptoms, she becomes bedbound. She continues to complain of that upper and lower extremity pain, but she has the onset of lower lumbar pain. And you would think that that would be a natural occurrence because she's bedbound. She maintains a reclined position. That seems pretty normal with POTS, but she keeps a pillow under her legs. Cervical spine still a problem. She has worsening fatigue. Now she's not working. She has cognitive worsening, insomnia, headaches, POTS. But she has the onset of this urinary frequency, and I think this caught my attention this time. She was urinating every 45 minutes. Now, of course, I thought, well, maybe we're pushing too much fluids. We did look at diabetes insipidus, see if there was some other cause for this urinary frequency. So she gets a consult because of the cervical spine complaints with the neurosurgeon for CCI, and that surgeon suspects tethered cord. And that was back in December of 2019. Because she didn't meet the criteria for hypermobile EDS or was on the hypermobile spectrum, we sort of kind of dismissed that and put that on the back burner. But after I began to learn more about tethered cord and some of the symptoms you might see, I encouraged her to go back and get a second opinion, which she did. At this time, upper and lower extremities still a problem, urinary frequency still a problem. So we sent her for urodynamic testing, which was abnormal. Her neurological exams had abnormalities, walking now any real distance was triggering pain. And on her MRI, we saw a low-lying conus. So the second neurosurgeon diagnosed her with tethered cord, and she had surgery of November of 2020. So it was about 4 years after the onset of her illness and about almost 2 years after her initial evaluation with me. So it only basically took me 2 years. So Dr. Petra Klinge came out in one of her presentations with these are the symptoms that she looks at. Dr. Yelman kind of spoke about them too. And they are bowel and bladder symptoms such as bowel incontinence or constipation. You see constipation more than you do incontinence. Of course, urinary frequency, urgency, retention, and frequent urinary tract infections, or perhaps the thought of urinary tract infections. There may be some spasticity, some hyperreflexia, clonus. And then we see orthopedically toe walking, club feet, leg deformities, scoliosis or kyphosis. So when I do an exam now, I do look more for scoliosis, kyphosis, or any kind of leg deformities. Then we'll see pelvic, lumbar, lower extremity aches, burning, fatigues, heavy, stiff, and tightness. So these are the adjectives that they will use to describe their pain. Interestingly, the pain will migrate, but it doesn't radiate. A lot of times these patients will discuss that they had growing pains as a child, and then, of course, increased pain when walking on an incline or stairs. This is just a consensus statement that talks a little bit more about that. So I came up with my own little clinical pearls so that I can have more of a systematic approach to these patients. So now this is during the initial evaluation. Here are some of the things that I just, if I hear, I kind of make note of and put aside. And so hypermobile spectrum, have they been diagnosed with that? Or else I will do that in my physical exam. Were they a toe walker, in towing, toe curling as a child, scoliosis, growing pains? And then they also talk about this pulling sensation on the neck. Not everyone, but that would be something I'd kind of put on the side, a little note that would make me curious. Then we have lumbar and lower extremity. So they're talking about their aching, burning, stiff, tight pain. It's increased from walking. And here's another one. They put pillows under their knees, or they sleep with their knees bent basically on their side. And then they have pain with forward trunk flexion, or that position will provoke their other symptoms, so that they may be provoked with post-exertional malaise because they do a downward dog, or they do a child's pose in yoga. So then we look for constipation or urinary frequency, neurologically, hyperreflexive, deep tendon reflexes, clonus. I typically see it at the ankle, tremors or spasms in both upper and lower extremities, and an antalgic or spastic gait. And the gait's really interesting. You have to be very observant because it's like a little hesitation in the gait. It's like as they go to step forward, there's this slight little hesitation there. Then you just look at worsening symptoms. So basically, I don't say go to tethered cord first, because many times there's so many other things we can do. But I would go there if we've done used so many of the tools that we had, and this patient was either getting worse or just not advancing in any way. Okay. So physical examination, that is, I would look at the spine, right? So we're looking at kyphosis or scoliosis. There are some clues in the lower spine. So we're looking at any kind of cutaneous manifestations, hairy patch, hemangioma, dimples, lumbosacral mass, caudal tail. What you might see, which is very interesting, is at the gluteal cleft, there might be just a little bit of a pull to one side or the other. And I would make a note of that. So you assess for hypermobility. Your neurological exam would include a pinprick, light touch in each dermatome in the lower extremity. That's very telling. You look at reflexes in the upper and lower extremities, and when you do the reflexes, you don't just hit the tendon once, you want to do it repetitively, and what you're going to see is more of a hyper-responsive or definitely a hypo-responsive reflex, manual muscle testing, and then your gait assessment. So here is the measurements for the Beighton score. Okay, then Dr. Yeoman talked a little bit about this. This is called the heel-toe screen, which can be very helpful. What you do is you have a patient, if possible, walk 20 feet on their heels, followed by 20 feet on their toes twice a day for 10 days. And the patient is logging how they feel. Do they have increased pain or symptoms in their low back, their legs, or their bladder? And like I said, it could be very telling. And then there's the differential, right? So I just want to remind you that motor and sensory deficits will not follow a normal myotomal or dermatomal pattern. So it's kind of jumping all over the place. Coughing and sneezing won't aggravate the pain. Lying supine will not make the pain better. So getting off of weight-bearing status will not make it better, and pain is intermittent. So these are imaging pearls, and I do not profess that this is a strength of mine, but here are some of the things that they're the reason why we're doing it. So we're ruling out other causes for pain. We're going to look at the level of the conus. Typically, if it's lower lining, it might be an indication of a pull. The cauda equina may be obstructed, so you won't get anything there, but we also look at phylum thickness, which is measured at L5S1, and I have found that even some of the top neurosurgeons are not able to really have a good sense by just looking at the imaging. And then you have to also recognize that scoliosis can restrict normal cord mobility. So that's something to consider when we're doing imaging. And then we have urodynamic testing. And then we also have to keep into consideration, there are other things, I'm just going to put this for your information here on this slide, that may mimic tethered cord. So are there treatments other than surgery? Yes and no. So it's interesting that tethered cord, the pain there may come and go. Sometimes it seems pretty severe, and then all of a sudden it will resolve and they'll be okay for another year. I do tell my patients to limit forward flexion, lumbar support, a foam roller under knees when long sitting. A steroid burst can be helpful, as well as lidocaine patches. And then the other things that we typically may use is like a COX-2 inhibitors or anticonvulsants that's pregabalin or gabapentin, tricyclic antidepressants. And then I do like to refer to physical and occupational therapy, which can be helpful. So the outcome for this case was amazing. And since then, I haven't really had an outcome like this. So within a year, these are her notes, within a year, her leg pain was gone, her leg weakness was gone, her burning sensation was gone, a leg tingling, heaviness, low back pain gone. Leg weakness was 80% better, and her urinary frequency was gone. This is certainly not typical. Now it's 5 years later and she's fully functional. She exercises. We would not consider her as having chronic fatigue syndrome or MECFS. So it was really a miraculous, very joyful experience at the end, despite my lack of knowledge. But what we can expect, and here's a nice little paper if you have time to read. What we can expect is that about 80% of patients will have some kind of improvement in some symptoms. There is this sentiment that a tethered cord release is curative of ME/CFS, with the exception of that one patient. I haven't seen that. And I've seen about 30 patients, maybe 35 patients who have had tethered cord release, and she's been the only one that's had more of what I would consider miraculous recovery. But one of the things it does do is relieve that pain and that urinary frequency and urgency. And it can help with some cognitive function, and decreased fatigue. So it's a way that we can get them out of bed and be able to use some of the other tools to improve their health. And that's all I have for you.
That was so wonderful. Thank you both for your presentation. We're going to transition over to the Q&A and discussion part of this. So I'm going to give everyone a chance to gather their thoughts. You're welcome to put them in the chat box. You're also welcome to raise your hand and unmute.
Great presentations, guys. So maybe I'm dating myself by saying this out loud, but I don't remember anybody talking about this when I went to medical school, but it has been a hot minute. But I feel like, what do you think are the barriers to people identifying this? I think the hard part sometimes is if there's not like a direct mechanism. I think people have a hard time connecting the dots together. So I'm just sort of curious what your thoughts have been on the barriers to identification for this.
I would say in my experience, radiologists are not really trained in identifying tethered cord in particular, especially even with those 3T prone and supine MRIs. I know sometimes a 3T MRI just in normal supine is sufficient for Dr. Klinge specifically, but most radiologists are not trained in it. I would say I've seen neurosurgeons look at people's MRIs and say, just as plain old supine MRI and say, this rules this out. We don't see anything on this. This rules it out. So they're just not even aware that you might need a higher resolution, that it's even on that high resolution and in prone and supine, it can still be very subtle and hard to predict. And a lot of times we're saying, yeah, we think based on the compilation of clinical symptoms and the fact that the imaging looks suggestive, but not completely sensitive, hey, let's go ahead and proceed with surgery. But that's sometimes the best answer we get. And so really very few people, I think, even in the neurosurgical world are trained in this or know how to identify it. And there's this overconfidence that we sometimes have as providers, like, no, we don't see anything on this MRI, therefore it's not there.
Yeah, I have to agree too. The other thing is now we're more aware of hypermobile spectrums or hypermobile EGS. So I think we're seeing that more often with that awareness. And just recently, as I look through the literature, now you're starting to see many studies that talk about adult tethered cord syndrome. So I think just as a community, we're becoming more aware that this is a possibility.
We have a couple questions in the chat. What is the incidence of tethered cord? Or have you been able to really put your finger on that?
That's a hard study to do, I think, because it can be so difficult to diagnose to begin with. I'm sure any incidence study that we might get would be severely underestimating this. And the reality is there are probably a lot of our patients who are walking around with some degree of tethered cord, but maybe not the complications that we discussed today, whether it be the symptoms or the neurological stretching. It may be very mild, but also something that 10 years down the road may actually become symptomatic.
And for those on the phone, I just want to make sure that they're aware that this question was answered in the chat. Does Gore-Tex pose a problem with patients who have CAS? And Dr. Yeoman, do you want to go ahead and answer that verbally?
Yeah, so like we said, they sometimes will put in a Gore-Tex to kind of prevent retethering. And of course, we presume that these patients may also have mast cell activation and they just had surgery. That could be a local area of inflammation. Could you even react to the Gore-Tex itself as a foreign body and have a mast cell reaction from that? The answer is, I don't know. I'm not aware of any data that they've, gone back in surgically and looked at the Gore-Tex later and seen that there's mast cell inflammation around those areas. Dr. Klinga might have some personal experiences with that in one case or another, because I've heard there's cases where it retethers even with the Gore-Tex. But I know for my patients, I always insist on as tight of mast cell activation syndrome control as I can, even before surgery going in. And I do wonder long term, I hope that that actually reduces the incidence of retethering and might prevent any mast cell reaction to a Gore-Tex or anything else. I don't know that to be true, but I certainly hope it's true.
We have another question in the chat. What are your thoughts on surgically correcting CCI or tethered cord first?
Teresa, do you have any comments first, so I don't dominate the conversation?
No, I was going to say, Dr. Yelman, why don't you take that one? But personally, I see the trend is to do a tethered cord release first and then do CCI. But that just seems to be the trend. So what are your thoughts, Dr. Yelman?
I think it, for me, is a very individualized decision. If somebody is progressing rapidly and decompensating in their symptoms, and those symptoms fit those of the cervicomedullary syndrome, and they're rapidly advancing, I think that you can make an argument for addressing the CCI or atlantoaxial instability first, or addressing them together, which is something that I know at least Dr. Gillette in Spain will do at the same time. On the other hand, if people are relatively stable, though you're just bumping up against a wall and not making progress, and it's very clear that CCI or atlantoaxial instability or some other neuroanatomical issue is sort of preventing progress, preventing your ability to control mast cell activation or control dysautonomia or sympathetic symptoms. And I also find that there's tethered cord. I think it's reasonable to consider a tethered cord release first, even if the tethered cord symptoms are not as bad as the CCI symptoms. And the sole reason is because, again, when you get rid of that anchoring at the filum terminale, can you now implement more conservative measures? Can you now be a better responder to cervical traction of some kind with Muldowney protocol or deep cervical isometric exercises, and actually be more responsive to those conservative measures for managing your CCI? Sometimes the answer is yes, but then you also have the other side of that, which is sometimes the answer is no. Sometimes that'll make the CCI worse. That'll make the CCI more symptomatic, because now you have no tethering. It's just sliding all over the place, and you're getting more actual anatomical irritation in those areas. And so you have this philosophical question, is that good or bad? I think you could argue, hey, if it was always this bad to begin with, doing a tethered cord release sort of brings that to light, and it's maybe better that we address this now rather than 10 years down the road when maybe it's had a chance to do even more irreversible damage. But if you're not ready and willing to move forward with the CCI surgery, if things were to get worse, then it's maybe not right to go ahead with the tethered cord release in the first place. So it really depends on where the patient's at, what their goals are, what they need to do with their life, how patient they can be, what you think their predilection for progression is based on the clinical care you've had with them. They've really decompensated over a year. They've been stable for 10 years. All of that feeds into that decision to me.
What are the benefits and pitfalls with saying it's tethered cord syndrome until proven otherwise? Teresa, you want to take that one?
Well, I think one of the benefit is that, if a patient is bedbound, sometimes we can't make progress without addressing tethered cord, or CCI. So that's a consideration. But one of the pitfalls are that there are things that we can do to improve function in a patient. And sometimes, even if they're very suspicious for tethered cord, we can improve function where they're back to, to work or have a life that is relatively functional. And if we are maybe a little too hyper-focused on tethered cord, we may miss that opportunity to help them resume activities.
What do you think are the best avenues to increasing medical awareness of tethered cord syndrome in infection-associated chronic illnesses, especially since it can be oculate and not always evident in imaging?
Well, I like to think that one of our best tools for perhaps really educating the medical population as a whole is physical and occupational therapy, right? They have a really strong understanding of anatomy and physiology, and I think that they can gently assess and suggest that these may be considerations. So I think it's I think it's possible when a patient's affected to have a home health physical therapy or occupational therapy come and do assessments. So I think they should be big players in this, but as in everything else, it's just a slow go in kind of educating our community.
I sort of see the paucity of neurosurgeons who even address this as a rate limiting step. And in fact, there are neurosurgeons who do address this congenitally, but they don't necessarily address it in adults who have acquired or occult tethered cord, which is frustrating for us who are taking care of these patients all the time. So, you know, if there's a way to get more neurosurgeons trained under the people who are helping us right now, that would be great. If they had more resources and money to do studies like some of the biopsy studies that I know Dr. Klinge was going to present on today, if we had more case series published, at some point it starts to get out there. But I think it's going to be, that's really definitely one of the big challenges. Certainly, even just having all of us address this, every one of us maybe having one patient who's had a tethered cord release and had a good outcome, and then they can kind of go back and teach their providers who are actually invested in their care. It does expand exponentially, just not as fast as we would like.
There are a couple more questions I want to get to in the next 10 minutes here. So do you see trends in lab testing in long COVID or ME/CFS who develop tethered cord? Do you have a hypothesis about who is at the highest risk for it and trends in the subsets who develop it besides MCAS severity?
Laboratory wise, I have not noticed any trends. I would say that the association with connective tissue disorders definitely catches my interest. But I would just caution to say that just because they don't reach a Beighton score that's impressive doesn't mean they don't have a connective tissue disorder either. I think we sometimes assume that. And as people get older and age, that hypermobility can be reduced. In fact, the sympathetic overdrive and dysautonomia of ME/CFS or long COVID sometimes creates this dystonic reaction in muscles, and you have overused muscles and underused opposing muscles, and this tight posturing. So many times I've seen massage therapists and physical therapists and craniosacral therapists say, "You're not hypermobile. You're the most tight, stiff person I've ever met," and that actually seems to come along with that as well. So the traditional ways we evaluate for hypermobility may undersell that it's still there, that we're just not recognizing it. So I don't use that universally, but I think there is a strong association for sure.
Thank you. Do you see providers pursuing radiofrequency ablation procedures such as Intercept because of the newness of it instead of tethered cord release? Do you think that's helpful?
In fact, I would say I have seen not radiofrequency ablations, but Dr. Gillette in particular has actually recommended, when he's not sure if somebody's pain is from their tethered cord or not, to go in there and have some of our pain specialists do nerve blocks, temporary nerve blocks, to see if we can get people relief until their surgery so they can travel, or even to say, hey, is this the cause of your pain, or are we actually dealing with one of these other complicated pathophysiologies that we see in these very confusing patients? So it can certainly be diagnostic to get lumbar spine nerve blocks. It can even be therapeutic for a temporary position. I haven't seen him recommend that anyone get a radiofrequency ablation. But perhaps, you know, if you have, and again, because you've got patients with hypermobility, you get all kinds of disc slips and all kinds of degenerative disc changes and stenosis. And hey, is this pain actually the tethered cord, or is it one of these other complications from, you know, everything that's been jostled around? Sometimes these interventions can give us some more diagnostic information so we know which direction to take.
Dr. Hoppers?
Hi, Dr. Yeoman. so I understand, do the nerve blocks, if strictly they have tethered cord and their pain is from tethered cord, will the nerve block help that? Or is it diagnostic in that it doesn't help it? Just so I understand.
My
Okay.
understanding, and I am not the expert in all the different types of lumbar blocks, but my understanding is that you can do specific blocks that would be designed for tethered cord. But if you're not sure, hey, is it this stenosis over here at L4, L5, or is it this slip disc, or is it, you can start with kind of the traditional blocks that we see in a traditional kind of pain clinic. Here, I'm going to block that nerve root there. Oh, that didn't relieve your symptoms. It must be the tethered cord. And then they can go back and do a tethered cord injection for temporary relief while you decide how to proceed on a more global basis.
Thank you.
Teresa, you touched on this a little bit with some of the different little cues, the pillow under the knees, the toe walking. Are sacral dimples likely due to tethered cord syndrome?
No, no, but it seems that individuals with sacral dimples are prone to like congenital tethered cord. So there's this subset that we have that maybe had partial tethered cord throughout their lives, and then they become, ill with a post-viral illness that changes that connective tissue a little bit more, and now they develop a tethered cord.
Thank you. One more question here. Is genetic testing for connective tissue disorders helpful?
That's a loaded question. So I think the problem with genetic testing is that it is not perfect for the majority of our patients with connective tissue disorder, which are those with the HEDS type, which is not a single gene type, right? In fact, we don't really have a specific constellation of genetic markers that give us that diagnosis. So you're going to miss those. However, if you have someone that you're not sure that they're hypermobile, but hey, everything else is falling into place and they seem like they could have tethered cord and CCI and mast cell activation. And, you could, if you were unsure, you could certainly screen for it and make sure you're not missing something different, like a Stickler syndrome, for example, that may not present in the same way with the same high Beighton score. I think the genetic testing helps when you're talking about helping these patients to get disability or get insurance to actually cover the procedures that we know that they need. I think also it seems to be coming standard of care for all of our neurosurgeons to test for vascular EDS prior to doing a tethered cord release or prior to considering craniocervical fusion because of the additional surgical risks of the vascular subtype. So if I'm prepping someone and we're leaning towards surgery, I'll at least do the COLA3, I believe it is, for the vascular subtype, just to make sure our surgeons are aware of that.
Really great discussion. Can you summarize how and why you tie in post-viral syndromes with tethered cord?
I'm not sure I quite understand the question, other than to say we're finding symptoms of tethered cord in a vast array of people with post-viral syndromes.
Well, I'll give you 4 minutes back to your day. And just as a quick reminder, do claim that CME by midnight tonight. Our next session is on Thursday, February 1st. We'll be hearing from Dr. Greg Condi and Dr. Yelman as they talk about sympathetic overdrive. That's something that we are certainly seeing a lot in this post-viral world, post-infectious world. So we hope to see you then. Take
Sorry
care.
if you're getting sick of me.
Take care.